It is my absolute pleasure to introduce Professor Hochhaus, who I'm sure all of you know in the audience, and he's going to be giving us the Asciminib conversation about the updated European LeukemiaNet 2020 recommendations for treating chronic myeloid leukemia.
Yeah, thank you, Nicola, and thank you everybody for joining this conversation here. It's a real pleasure to share with you that means 34 experts from Europe, America, and the Asian Pacific areas did in the last 3-4 years, putting together all the evidence, putting together all our expectations, all the experience for recommendations for the management of CML. We call it recommendations, we don't call it guidelines, because guidelines, to produce guidelines, we need a very, very specific procedure. Recommendations are more based on the personal experience and the data from the literature in a mix. Yeah, and it's not the typical evidence-based guidelines. Of course, the recommendations are evidence-based as well, but based on the personal experience of all the 34 people. I'm happy to see some very, very well-known people in the audience. We have colleagues here, physicians here, even people who participated in the panel. Anna Turkina is part here of the audience, and I've seen Giora Scharf. Giora Scharf is one of the most important and famous patient advocates worldwide, and I'm proud to be, at least in part, his doctor for CML. I'm happy to greet you, and for everybody, Giora has the most demanding questions for us all the time, and I think he will have some questions today as well. So, but what did we in this work here? We send out to the 34 people 5 sets of key questions, and what we expected is at least 75% agreement for the answers of these questions. If this was not the case, we asked the question again, we discussed this topic, and we had some points with disagreement, but this is clearly stated and in the guidelines that this was not agreed for all the experts in the panel. It's important to realize that the cost of these meetings and the preparation of the reports were covered entirely by the European LeukemiaNet and not by any pharmaceutical company. That means pharma companies were not involved in the production of these guidelines. You see here the front page of the guidelines, which appeared in Leukemia earlier this year, early enough to call it 2020 recommendations for treatment of CML. The most recent recommendations were from 2013. That means 7 years in between, and a lot of things happened in these 7 years. We have new drugs available, we have new measures, new endpoints, we have the TFR as an option, as an endpoint, we have changes in the pregnancy problem, and all this is being discussed in this paper. And I want to go through the most important parts. So, and the first question is, of course, when you meet a newly diagnosed patient, what is the goal of the treatment? For all the patients, it will be to reach a normal survival with or without CML. But the new point here is, in addition to life quality, to tolerability, is, and this is new, the chance to achieve treatment-free remission. And this may influence the choice of the first-line treatment, and therefore it's important to realize this. We state in the guidelines, in the recommendations, that we want to do a shared decision-making with the patient, and to do a shared decision-making, we need, of course, the information. The patient needs to be informed very early in the course of the disease. That means ideally before first-line treatment is decided on. What are the options, and what should I consider when I choose one or the other drug for the first-line therapy? We have now the positive outcome for survival, looking here at the last almost 40 years of CML management. That's the example of the experience of the German CML study group. We started with chemotherapy, and almost everybody died on CML in the median after 4 to 5 years, except the patients who had the chance to be transplanted. But now, with the introduction of interferon, the curves shifted, and with imatinib, that means the first tyrosine kinase inhibitor, we have now consistently in national trials and also in the international IRIS trial and 10-year survival of 83%. This is very close to the normal expected survival, which is about 5% higher. That means we have an excess mortality of 5% now for a CML patient, which is too much, of course, needs to be reduced as well, but is in comparison to the 40 years ago or even 20 years ago, it's a big step forward. And this needs to be considered when we compare treatments. And just to mention it, we have no difference in the 5-year and longer survival for the different tyrosine kinase inhibitors. Therefore, this should not be a point for the decision making for an individual patient. We need other endpoints when we want to choose between the different drugs. So when we see a newly diagnosed patient, we need to know what to do, which workup to do at baseline. Of course, that's standard in internal medicine to do a physical examination. But what we need to see is the spleen size and the liver size, because this has prognostic impact and may influence the early course of the treatment. We need a complete blood count. We ask for a microscopic differential, not only the automated differential. We know that the specific left-shifted myelopoiesis is being seen, revealed much better with a microscope than with an automated blood counting. We still ask for a bone marrow aspirate at diagnosis to get a cytologic examination. In the individual patient, we may see differences in the blast count between bone marrow and peripheral blood. Therefore, it's important to have the bone marrow at least an aspirate for cytogenetics as well. A core biopsy was not agreed in the panel. I'm personally in favor of a core biopsy at diagnosis, because we may see a fibrosis, and fibrosis has prognostic impact as well. We ask for this core biopsy only if there was a dry tap. We know we need the chromosome bending analysis. Beams are bending or similar. The very popular FISH analysis, which is popular in the United States, for instance, is not needed when we have a standardized PCR available. We only need it in case of Philadelphia negativity, which may happen in about 3 to 5% of cases. In this case, we should see the genomic rearrangement with FISH analysis. But we need, and this is really important, a qualitative RT-PCR analysis for the type of the BCR-ABL transcript, because when we aim treatment-free remission and when we aim deep molecular response, we should know from the beginning what we really measure. And when we see an atypical transcript, of course, we need specific PCR strategies for the follow-up, and it should be known from diagnosis. Therefore, the identification of the transcript type is really important. We need an ECG since all TKIs may have an impact on the QT time, and to see aberrations at diagnosis before we start with a TKI, and we need biochemistry. And now most companies demand and hepatitis B serology for their tyrosine kinase inhibitors. There are rare cases with reactivation of hepatitis B. Therefore, it's important to measure this at diagnosis. So when should we start the tyrosine kinase inhibitors, and in which cases we need Hydrea? Hydrea is, of course, a rapidly acting drug, which may be important when we see very high blood counts, but only if BCR-ABL is not known. As soon as we have the BCR-ABL transcript by RT-PCR or cytogenetics diagnosed, we don't need to use Hydrea. We can start immediately with the tyrosine kinase inhibitor. This has been a rumor in the literature that we should get down to 50,000 leukocytes before we start TKIs. That's not the case. There is no major problem of tumor lysis when we start with the TKI immediately. So, and patients are, of course, very individual, and we may treat patients on their individual performance and their individual status. And one of the key questions for the patients is, which is my prognosis? Do I have quite normal CML, or do I have specific parameters which indicate an unfavorable prognosis? And this has been discovered on 4 different scores, and the most recent score is the European long-term survival score based on age, spleen size, blasts, and platelets. The endpoint for this is CML specific survival. The first time in the course of the development of these scores, CML specific survival, that means all CML unrelated deaths are not considered here in the calculation of this score, and this leads to a very specific prediction on the next slide. This prediction of the ELTS for overall survival and for leukemia-related deaths, LRD, is much more specific when you compare high risk, for instance, SOCAL and ELTS. You see more, 12% of patients who are in the 6-year leukemia-related deaths category compared to 8% with the SOCAL. That means we can predict leukemia-related deaths much better with the ELTS score. Therefore, we use the ELTS. We recommend to use the ELTS. Fortunately enough, the parameters which go into these scores are identical for SOCAL and ELTS, but the way of calculation is different. And of course, this is available online, the score calculation. Therefore, it's easy to calculate. And we recommend ELTS now for all studies and for all patients. So, and then we have biological parameters. And one important biological parameter, and that's the reason that we need cytogenetics at diagnosis as well, are the additional chromosomal aberrations. We see here curves from the German CML study 4, indicating that trisomy 8, a second Philadelphia chromosome, and the derivative 3, 7, 17, 19, and 21 have impact on overall survival when they are discovered at diagnosis, but also later in the course of the disease, because these are major root aberrations which have an impact on the risk for blast crisis. That means these aberrations may herald advanced disease and are therefore important. And if we have a young patient at diagnosis with one of these aberrations in the Philadelphia positive clone, that's a risk, that's a warning, and it will go into the warning category now because such a patient may be a very early candidate for allogeneic stem cell transplantation. So, and then we ask for the first-line therapy, and this was the point of the most important and longest discussion. we had colleagues in the groups who advocated for imatinib at diagnosis for everybody and to switch treatment when it's needed for non-response or lack of response or a lack of tolerability. Since we see that higher risk patients have an advantage from the use of second generation drugs, some colleagues advocated for imatinib for low-risk patients and the second-generation drugs for higher-risk patients. And others ask for a very individualized decision based on the treatment aim. That means the goal of the treatment. If TFR is the aim of the treatment, as second-generation drugs may be preferred over imatinib. But imatinib is not wrong, since we may achieve with imatinib a TFR as well. But the deep molecular response dynamics is, of course, slower with imatinib compared to the second-generation drugs. And this is left open. That means we recommended to use one of these 4 drugs for the initial for the first-line treatment of CML. My personal view is number 3. That means I discussed this with the patient very openly and include, of course, the side effect profile of each drug as well. But with the fastest chance of DMR, we are, of course, better off with the second-generation drugs compared to imatinib. Survival, I already mentioned, this is no different between the second generation over imatinib. All these differences here from the studies are not significant. Therefore, we cannot use overall survival as a trigger, as a management trigger for choosing the first-line treatment. But we can use the early progression. These are data here from DASA, from Dasition and from NSND and from the before trial. And we see a trend, which is significant for NSND, for nilotinib, but not calculated in the significance for dasatinib and too early for bosutinib. But we see a trend that we can rescue patients who would get an early accelerated phase or blast crisis with imatinib, but not with the second generation drugs. That's an argument to use second generation drugs earlier. The early years of treatment, accelerated phase and blast crisis. More important is the molecular response dynamics. We know that a patient who has more than 10% BCR-ABL at 3 months, that means a lack of early molecular response, has an unfavorable outcome. Therefore, we want to achieve a higher rate of early molecular response, which is the case for dasatinib, nilotinib, and bosutinib over imatinib. We want to achieve a deep molecular response for treatment-free remission studies, and we want to achieve MMR in most patients because we know that MMR is a safe harbor for all the patients, and this is achieved much earlier with the second generation drugs over imatinib. That means the molecular response dynamics are an argument in favor of the use of second generation TKI over imatinib. However, we have, of course, the side effects, and we discussed the side effects in the recommendations in detail. And for nilotinib, we see, of course, cardiovascular problems. And you see here the 600 and 800 milligram cohort of nilotinib in NSND compared to imatinib. And there's a striking difference for the incidence of cardiovascular problems. But this is a time-dependent variable. That means starting with second-generation drugs, here in this case with nilotinib, and deciding after 3 years whether we can stop treatment or probably change treatment because we want to avoid a later cardiovascular risk is of course an option. But we know that to choose an individual patient according to his history and to his other diseases which may happen in parallel to CML is an important parameter as well. Next, we see from NSND that the risk for cardiovascular events is mainly in older patients, over 60 and over 75, the very elderly. We see a much higher incidence of cardiovascular problems as compared to the younger patients. That means in older patients, we should have a look at the cardiac or vascular situation, on the cholesterol, on the hypertension, and we may avoid nilotinib in this situation. This is important. That's an individualized treatment choice based on the other diseases which are in parallel to CML. And this is shown here on this graph. We have here women and men, we have smokers and non-smokers, the hypertension, we have the cholesterol levels, and all this together indicate us when we are on the safe side for the use of nilotinib in the green area, and when we are on the unsafe side, which is on the red and brown area here. Such charts may be used to choose the individual drug for the individual patient. And on the other hand, next we have dasatinib, and in dasatinib the problem is the pleural effusion and lung diseases, and therefore I would avoid, in case of pre-existing lung disease, I would avoid dasatinib. But for all other patients, we don't see the difference for the side effects to imatinib, and therefore it could be used in all other situations. That means dasatinib has the same very similar profile for the achievement of deep molecular response as nilotinib, whereas we don't have a comparative trial, but we have the comparison with imatinib, and therefore it can be used as well to achieve an early deep molecular response. So, and this is, I think, is the most important table in the recommendations. It's an update of the previous table with the treatment milestones, with the endpoints. I already mentioned that the high ELTS score and the additional chromosomal aberrations at diagnosis are a warning sign if they happen at baseline. I refer to the high-risk ACA, which I mentioned earlier. And we have the 10% level at 3 months. And in the 2013 version, we were a little reluctant to set such a specific cut point as a trigger for treatment change, because it's one PCR only, and one PCR may have some inaccuracy. Therefore, we ask for confirmation, and in the last version, 2013, we asked for the confirmation after 3 months. Now we ask for the confirmation immediately. That means between 1 to 3 months, and if this is confirmed, it's a failure sign, and treatment should be changed. At the end, the failure is 1%. We know that patients below the 1% level have a risk for acceleration and blast crisis. Therefore, we want to achieve at least 1%, but we consider 0.1 to 1% as a warning sign, because the safe harbor is, as defined in IRIS, 0.1%. And the line below the table is important for patients aiming at TFR. The optimal response is 0.01%, but this does not mean that more than 0.01% is a warning. Therefore, it's separated here in the table. But if you want to achieve TFR, the 0.01% level is important. So these are examples here only. We can go through very fast. The 10% level from the German CML4 study here clearly separates from the 1 to 10 and less than 1% at 3 months. And next, we have the major molecular response. And the major molecular response is not only a marker for the stability of the disease, but also for the chance to achieve a deep molecular response at later time points. That means we have the chance to achieve an MR 4.5 or undetectable BCR-ABL much, much better when we see at 3 months a major molecular response. This is, of course, the minority of patients, but illustrates that an early molecular response is a trigger, is a marker for a TFR chance at a later time point. So I already mentioned IRIS, and in IRIS, the term major molecular response was defined based on this table. Here are patients, 164 who achieved after 18 months and major molecular response, and 89 who did not on imatinib. And these triggers a survival difference. And this is important. This was the first time that a survival difference was discovered based on the MMR achievement at 18 months. And therefore, the MMR is for us the very positive endpoint, the treatment aim, the milestone for a good response at 12 and 18 months. So we need to define and standardize BCR-ABL. This is a small chapter in the recommendations as well. This has been published in other papers by Nick Cross and others. But we define MR4 as 0.01%, MR 4.5, 0.0032%, and so on. And we need minimum levels of ABL or GAS-B to have the sensitivity to be able to define these molecular response levels. This is important and defined in the recommendations here as well. So now we have resistance. We need alternative drugs if we don't achieve or if the patient loses the response for various reasons, depicted here by Jane Epperly. Compliance is important. We need to ask for alternative drugs which may influence the absorption of the metabolism of the TKI, and what counts is the intracellular level of the TKI, and if the intracellular level is too low, mutations may be selected and create resistance. If we see this resistance, we should know, and we give some guidance which drugs should be used. Here again, we have, this is in a second paper, we defined what is the treatment beyond second line. I mentioned the 1% level. If you don't achieve 1% after 18 months, we should discuss a treatment for second line and even later. That means we may use all the 6 tyrosine kinase inhibitors available, but at the end, the situation will not go better if we don't achieve at a level below 1%. And this is the trigger for the decision towards allogeneic stem cell transplantation. For the mutations, if we discover a mutation here, we have in the recommendations a very precise recommendation which drugs are sensitive to which mutations. So, and then we have the different lines of treatment and what can be used on second line. And as mentioned, starting on second line, we should consider allogeneic stem cell transplantation if we see specific markers, and these markers may be additional chromosomal aberrations these markers may be cytopenias, recurrent cytopenias, or high so-called indices. And in the situation of the 315 mutation, of course, ponatinib is a drug of choice. For all the others, we can use alternative drugs according to this table. Here you see the use of ponatinib. It's very active in 315, but also active in other mutations. But you see the limitations. It's a good salvage drug, but the response is in about half of the patients on average. Major molecular response, half of the patients here, and at later time points, even less. That's important to consider. That means to use all the drugs available may not be a good choice for all patients if we see problems, additional problems in the biology of the CML. What is the right dose? Right dose is in particular important for patients who have side effects. Do we need the full dose? And we have defined that a slight lowerage of the dose for dasatinib may be useful. For nilotinib, 300 milligram is now for frontline treatment and after intolerance, the dose of choice. For ponatinib, it's still open. We know that with 45 milligrams, we see more cardiovascular side effects. Therefore, there is the OPTIC trial still ongoing. We don't have the results, the final results, but there is indication that the 30 milligram will be a good long-term treatment in some patients with a good response, even 15 milligrams of ponatinib once a day. So that's, I already mentioned this, recurrent neutropenias in conjunction with a high SOCAL and with lack of cytogenetic response to the first-line treatment is a negative indicator for long-term outcome. Therefore, we should consider in such patients earlier an allogeneic stem cell transplantation. We currently transplant, at least in Europe, more patients in advanced disease compared to early chronic phase. And this is actually the disaster, since the outcome of a transplant in advanced disease is worse compared to first chronic phase. Therefore, considering all the triggers which I mentioned in the course of disease is important to go to the transplantation in the minority of patients where transplant is needed earlier in chronic phase and not in advanced disease. So we have then some additional biological factors. That means we have a clonal evolution over time in CML with additional chromosomal aberrations, but also BCR-ABL mutations. An example shown on the next slide. We see these different aberrations, which are in addition to BCR-ABL on the same clone and also on alternative clones possible. And the recommendation in the guidelines is that such mutations may have an impact on outcome, but the final data is not available. Therefore, we need to do some research still on these additional mutations, on these mutations in the BCR-ABL positive clone. These mutations may be pre-existing and may harbor the BCR-ABL in this clone, but they may happen also as an evolution of the BCR-ABL positive clones. Either of these directions is possible. So now treatment-free remission. Of course, everybody knows that treatment-free remission is now the aim of the treatment for most patients. In most cases, of course, younger patients who plan a family. The vision for the next 5 years is that more CML patients will successfully achieve treatment-free remission because we work on that. But now we cannot promise TFR for everybody, but we can at least discuss that this is an option for a newly diagnosed CML patients. And therefore, the achievement of deep molecular response very early in the course of the disease is a good endpoint, as a good aim of treatment. And we defined, this is the well-known Euroski, 50% are stable after MR4. And we know that with second generation drugs, no, this is first a Euroski again. We know that with a longer MR4 duration, the chance to be stable in TFR is higher. This shows this graph. Yeah, we have a 3-year increase per year. And we know that the chance to go into the TFR is higher with second generation drugs. Data from NSND showed 38% versus 22% between nilotinib and imatinib. That means the outcome is the same, about 50% stability, but the chance to go, that means the size of the cohort goes into the TFR is higher with nilotinib. And we see on the next slides, we can go fast through it because it's well known. We see that the outcome is similar to STIM and Euroski with 50% stability. But the good news is that the Rechallenge with a tyrosine kinase inhibitor produces good responses as well. Here in this situation, of course, we should balance between cumulative side effects which may happen and the response. Therefore, also a change of treatment is possible. But we know that if a patient tolerated the drug very well and achieved a deep molecular response, I would use it again. But if we have a risk for cumulative side effects, then of course we may change treatment. So, and this is an important table. I will not go through all the different lines. You can read it in the guidelines, but these are mandatory, minimal, and optimal recommendations. That means what should be achieved until we stop treatment and what is optimal. And you see that the duration of TKI therapy and the duration of the deep molecular response is longer when we call it optimal compared to minimal. But what we need to know is already mentioned, the type of the BCR-ABL transcript, and we have mandatory requirements. And this is, of course, a well-defined structure. That means that the PCR results are rapidly available and used for the management of the CML patients after discontinuation. And of course, that this treatment option of TFR is being discussed with the patient in detail as a shared decision-making, again. So TFR is, of course, hopefully the end of the journey because we want to stop forever, which is being achieved in about half of the patients. In some cases, it's very urgent because in women who want to get pregnant, we need to stop the treatment. And we have some guidance here in the CML recommendations as well. TKI treatment should be discontinued in the first trimester as soon as pregnancy is confirmed. And of course, the fetus should be observed in detail when pregnancy happens during TKI treatment. Ideally, a woman who wants to get pregnant should stop TKI treatment according to the TFR recommendations earlier. The good news for men and for the families is that men taking imatinib, bosutinib, dasatinib, or nilotinib, we did not see an increased risk of abnormalities. Therefore, there is no specific recommendations now needed. That means men can father a child with these drugs. With ponatinib and Asciminib, data are very spare or absent. Therefore, we should be cautious with these two drugs as well. So, and we have, of course, some outlook And the outlook is the new drug. New drugs are mentioned because we can use new drugs in the management of CML in the frame of trials, of course. And it is important that we mention trials because we should always look for trials when we have a difficult situation with our patients. And the current example is the development of Asciminib as a myristoyl inhibitor of BCR-ABL. Asciminib is very specific for the BCR-ABL inhibition, and therefore it may be used very early in the course of the disease, but it is still open. The current development is towards third-line treatment. That means a salvage therapy when first and second line did not work. But of course we know, and I mentioned this, that we had cytogenetic and molecular clonal evolution during the course of the disease, and this is not covered by Asciminib. Therefore, the overall results, at least in the phase 1 trial, are on the average 50% response rates again in third-line treatment. It's a good salvage for some patients, but my expectations is that we will see Asciminib earlier in the course of the disease. Okay, next, I think that's it for CML. We have here the next 4 slides is a small summary what has been achieved in the 4 versions of the CML recommendations. Just to remind you that the first milestone in 2006 was complete cytogenetic remission. Nobody was talking about molecular remission. This was in 2009. And now later we talk about deep molecular remission. We talk about TFR. We have 6 drugs available when we consider the experimental drug Asciminib as well. And we still need to consider allogeneic stem cell transplantations for a minority of patients. And our major concern is now for the long-term treatment of CML, the cumulative side effects of tyrosine kinase inhibitors. And therefore we should watch the side effects, and we should consider the potential side effects when we choose a specific first, second, or third line treatment. That's the current situation. It's complicated. That means CML is still a complicated disease, but it's a very positive disease because the outcome of our patients now not only survival, but also the higher cohort of patients, the bigger cohort of patients who is now in treatment-free remission is very promising. Thank you very much for your attention.
That's fantastic. Thank you, Professor Hochhaus. Thank you so much for that extraordinarily comprehensive overview of the recommendations and also sort of how they came to be improved this year. We can stay and have questions. We have a couple coming through. Let me start with one. We talked about Giora right from the beginning. Giora had a question. Does the transcript type actually influence treatment choice when initiating therapy?
In the guidelines, there is no mention on that because the data is limited. When we have atypical transcripts, we have a problem of standardized PCR. My recommendations is to compare the initial level of BCR-ABL, patient-specific initial level to the endpoint after 3 and 12 and so on months. That means for the monitoring, it's not that important problem. But for the prognosis, we have indications that patients with E1A2 and E6A2 may have an unfavorable prognosis, but this is not consistent in the literature. My personal recommendation is to use a second generation drug in this situation. The E19A2 was even more difficult in the literature. The earlier reports were negative, but now we know that the E19A2 patients have a very positive prognosis, as others have. I'm cautious with specific recommendation, but we know that the shorter transcripts E1 and E6A2 may have a very aggressive disease, and therefore I would treat them with second generation drugs.
Okay. I guess, so another question about initiation of treatment. The question came through about the need for any induction treatment with hydroxyurea.
Yeah. No, I mentioned this in the talk, and I want to go into this because it's important for our consultation of new patients, if you are asked by new patients. Hydrea only in case of very high leukocyte levels, very high means over 100, or symptoms. If a patient is symptomatic, of course, he needs to lower the leukocytes as soon as possible. And if we don't have BCR-ABL, we should start with Hydrea. If we have BCR-ABL available, we can start immediately with any of the tyrosine kinase inhibitors. No delay.
Okay, so other questions sort of moving towards treatment-free remission. If we have a couple of these questions. So a couple of questions talking about, is there any consideration taken into the rapidity of deep molecular response being attained to the success of TFR?
Biologically, I would say yes, but data is limited. Yeah, because in most of the TFR studies, we did not start at diagnosis. That means we don't have a standardized PCR assessment for all the patients available from diagnosis, at least for the company-based trials and also for EuroSki. We started these trials in patients who already achieved a deep molecular response. Therefore, the initial phase is, the data on the initial phase is limited. But from the biology of the disease and biology of treatment, I would clearly say yes. The more sensitive the clone is, the better is the chance of being stable after discontinuation. That's my prediction, but we need more data on that.
Okay, thank you. Another question sort of comes through a couple of times about TKI withdrawal, so as part of TFR, yeah. Achieving TFR, and any specific treatment for that.
Yeah. So, the TKI withdrawal syndrome is, of course, a concern. And since patients who are in TFR may be well educated and know what muscle pain, joint pain, and pain in the bones, bone pain means, it may mean blast crisis. And therefore, it's a big concern. Therefore, we should discuss this with the patient before we discontinue treatment, that this may happen. That means the concern should be lowered here. And if we see a major pain, which is in the minority of patients only, but I had some patients who had a major inflammation in the joints, and with severe also inflammatory parameters in the blood counts and so on. In these patients, of course, a COX inhibitor or any other drugs or also steroids may be used. I mentioned several times in talks, of course, this is my personal experience and guidance, not part of the ELN recommendations, that in this situation with a very severe inflammation, ruxolitinib is a good drug. That's of course a surprise, because ruxolitinib is a drug for myeloproliferative disorders, but it inhibits JAK, and JAK is the major driver for this inflammation in this situation. And we may use a very low dose. It's off-label, very clear off-label, but we can start with a low dose and can taper the drug. In 4 weeks, everything is gone. That's my experience. It works well, but I say it again, it's off-label and not part of the ELN recommendations.
Okay. Question about interferon. So interferon, still viable treatment, sort of either in combination or after TKI therapy?
Interferon is going to be a disaster. And I explained why. I'm a friend of interferon. I like interferon, and we have very good data. The French SPIRIT trial showed that the combination of interferon with imatinib has an advantage over imatinib alone. With second generation drugs, similar data have been produced. We know that we can bridge with interferon before we aim a proper TFR. That means after discontinuation of the tyrosine kinase inhibitors, give interferon for a year. We do the TIGER trial. Results are not available now, but we have many indications that this immune response, which is triggered by interferon, may help to stabilize the treatment-free remission. But what is the disaster? The disaster is that all the companies who produced interferon struggle. First was MSD producing PEG-Intron. They discontinued the production, is now not on the market anymore. The next is Roche with Pegasus. Pegasus will be discontinued in production in 2022. And the third drug is now the Austrian drug from AOP, the ROPEC interferon. It's in some countries on the label for MPN disease, but not for CML. But it's a small company. The production capacities are limited. The study capacities are limited. I see interferon is going away. I predict this for the next years, which is not good, because it's a completely alternative mechanism in conjunction with the tyrosine kinase inhibitors, and it works very well in combination, and therefore it's a shame. And I would ask all of you to go to the companies and to alarm the companies about that. It may help, we don't know that. But I think the letter from Roche was very clear. That's our final decision. We will not produce Pegasus anymore, but we may find alternative companies producing a pegylated interferon for the use in CML in the future.
Fair enough. Okay, so perhaps with our final question, we can look to the future. So going from interferon right through to the most recent study results published by Novartis the other day, looking at Asciminib versus ponatinib. How do you see the role of Asciminib as the new TKI?
Yeah, Novartis is aiming to go on the market with Asciminib for third-line treatment, and that's okay. I agree with that. It's a good salvage drug for third-line treatment for about half of the patients. That means biologically, these are the patients who have still BCR-ABL dependent disease and not BCR-ABL independent mechanisms of drivers. Of course, biology, cytogenetics, mutation analysis may help to individualize treatment here, but I see Asciminib earlier. As a specific BCR-ABL inhibitor, I see it as a first-line drug or as a drug which may help to improve deep molecular response for a patient who did not achieve a deep molecular response. That means the add-on strategy. We do in Germany a first-line trial now, the Fascination trial, in combination with the other tyrosine kinase inhibitors. We have good experience. We have now half-year data available, and the half-year data and the tolerability look very nice, and for the efficacy as well. That means, in my opinion, it will be a good add-on for the first-line management of CML.
Excellent. Thank you. Thank you again.